noted, there is a resilience for females with regards to some psychiatric conditions and a vulnerability towards others. And this is something that's interested me both clinically and from a research perspective.
Many women, and I'll show this on the next slide, get very mixed messages as to whether they can take psychiatric medications during pregnancy. The reality is we don't have enough research on pregnant women with psychiatric illness during pregnancy, on the proper management of psychiatric illness during pregnancy. This is a quote. We're actually doing a disservice to pregnant women by routinely excluding them from clinical trials. As a clinician, I can tell you that when you have a patient who's pregnant, that's really when you want the most data. You want to know, can I prescribe this medication? And the data is very clear in the literature that exposure to psychiatric illness isn't good for pregnancy outcomes and isn't good for the baby. I can tell you that the relapse rate for major depression in women who stop their antidepressants for pregnancy is 70%. The relapse rate for bipolar disorder is 85 to 100%. In women who have successfully given birth in the year following delivery, suicide is the most common cause of maternal death. The conversation needs to be about the risk with the medication versus the risk of untreated psychiatric illness.
What we see in the lack of diagnosis of women with autism is a bit parallel to what you see for heart disease. And the problem in diagnosing all these women too late is that we could have avoided all these secondary psychiatric problems if we had acted before. There is up to 70% of suicidal ideation in women in their 40s and 50s who have high-function, normally intelligent women with autism.
And then there are biases in provider interpretation of patient behavior. There is the fact that the evidence says that female doctors provide more psychological support normally during the conversation. Instead, male providers insist more on the evidence-based aspect. So they spend more time on presenting, for example, tests and clinical results rather than discussing how do you feel. People are confused. Because as soon as they are confused, especially in healthcare, they go online and then the disaster starts.
We need to focus on the next generation, but there needs to be a shift in mindset. How do we achieve this?
And if we're going to get rid of the stigma, then we need to be speaking up about these illnesses.
Communication is still is getting more and more important in medical education, in healthcare professional curriculum, but we are still not there to develop assessment instruments which are more flexible to account for the differences of patients.
And I suspect that one of the other areas that's going to develop, that's going to help us, are going to be biomarkers, neuromarkers, well, markers that can be used in the clinic easily that will perhaps help us to fractionate out people into different subtypes for treatment and also help with the diagnosis of people that will be devoid of some of the biases that perhaps humans, for a variety of good and bad reasons, tend towards.
And one of the things that we are talking about and that is starting to happen is co-localized care. So psychiatrists don't make money, but we save money. And if we are in an OB-GYN clinic and can be advising and teaching the OB-GYNs who are on the front line about how to treat psychiatric disorders, we actually reduce costs.
We need more research. We need more biomarkers and assessment instruments in making sure that we have the right tools to diagnose. And then we need to enhance our communication that includes the education.